Wow, well, thank you all. Welcome to the fall ESPM seminar series. It's great to see. I want to first thank Lucas and Daniel for taking time out of Burning Man to come here and put a fantastic seminar series together. So I really want to thank them for that important service. I'm really excited about the way it's shaping up this year. In particular, we're looking inwards a little bit and looking at what some of us are doing and sharing that amongst ourselves. I think that's important. I have the pleasure of introducing Rachel Morello-Frosch. She is an environmental health scientist, an epidemiologist, a professor in the School of Public Health, and ESPM, and an all-around fantastic person and colleague. She's a renowned expert on structural determinants of environmental health inequalities. She's a leader in applying community-based participatory research methods to address environmental justice questions in the context of climate change and the effect of toxic chemicals and pollutants on community health. Rachel holds a BA in Development Studies, a Master's of Public Health and Epidemiology and Biostatistics, and a PhD in Environmental Health Sciences, all from the University of California, Berkeley. Didn't go very far, did you?
I would have waited for a while.
Oh, yeah, you did. You're calling out, yeah. You got to go away to come home. Right? She's published over 180 articles in scientific journals such as Environmental Health Perspectives, PNAS, New England Journal of Medicine and Science, and her work has been covered extensively in mainstream and Latino press outlets. When I first decided I was going to write a textbook on environmental justice to teach that concept to undergraduate students, Rachel was one of the first people I reached out to. In addition to her scientific articles, she is a co-author of the book Contested Illnesses, Citizen Science, and Health Social Movements with Bill Brown, that's right. Which examines the role of social movements in shaping scientific understanding of environmental health problems. Rachel is an elected member of the National Academy of Medicine and serves on the Biden administration's White House for Environmental Justice Advisory Council. And she's on the board of directors of Grist Magazine. Please join me in welcoming Rachel.
Okay, so first I want to say it's really great to be back. I disappeared into the central campus vortex and didn't participate very much in departmental activities as a result. So I just finished that gig after 3 years, and it's great to be going back to meeting, seeing my colleagues, and the best thing also is seeing a bunch of new faces of people who have come to the department in the 3 years that I've been away. So I'm hoping to get to know you all in the coming years. So thank you for having me, and I look forward to sharing my work with you. And please interrupt me in the middle of the slides if you have questions, and if I don't get through everything, that's fine too, because I feel like we're coming together to share our work. It doesn't have to be like, this is not a job talk. Luckily. Thank goodness. Okay. So I want to start with a premise, as a scientist who does a lot of work with communities that are impacted by environmental hazards and who tries to collaborate. Not all of my studies involve community engaged participatory research. I have some more kind of traditional scientific studies as well that don't, there's a continuum of community engagement in my work. But ever since being a graduate student, I've always thought about the ways in which social movements influence scientific thinking. And I don't mean just environmental science, I mean research, academics, the way we think about our research, how we continually reconceptualize problems, and decide what kinds of questions we want to ask. And I think that's super true, particularly around environmental justice research. And that also influences, these movements have also very much influenced funding streams and funding incentives So for example, a lot of my grants come from the National Institute of Health. And as a result of decades of environmental justice organizing, the National Institute of Environmental Sciences, which funds a lot of work of people in my field of environmental science, they basically created funding incentives for scientists like myself to do deeper and more sustainable collaborations with the communities that we were studying as partners, in terms of co-knowledge production. So for example, if I wanted to submit a grant to create the center of this, that, and the other thing, to study whatever it was that I'm interested in studying, I needed to have a community partner as part of that and demonstrate that the proposal had been developed, co-developed, and be clear about sort of the role of community expertise in the scientific work that we're doing. And these funding incentives for us enabled us to actually provide resources for communities to work with us. And this has been going on now for several decades. Many of these relationships of these different kinds of environmental health centers and scientists have been going on for quite some time. And this has influenced how scientists like myself and many others hypothesize how we think about environmental links to disease and attempt to do our science better. And so what do I mean by that? Well, so one of the big things I think that has improved the field of environmental health science is environmental justice advocates with whom many of us have worked have really sought to get us to do our science better in two main ways. One is, let's think about structural drivers of environmental degradation. Let's not just like do sampling, but let's sort of move things a little bit upstream and figure out why pollution appears where it does, why certain communities are exposed, etc. And let's do our job better and not analyze one chemical at a time. Let's not analyze one pollution source at a time. Let's really think holistically about the fact that people experience multiple hazards in the environments in which they circulate. And this has been a big tenet of environmental justice organizing and pushing both academic scientists, but also regulatory scientists to really think about things like chemical mixtures, multiple pollution sources, etc. So that's one tenet, kind of multiple hazards. Scientists, do your job better and really try and characterize multiple hazards. The second element of scientific challenge, I think, in terms of our community collaborations, has been how do we take into account that certain populations are more vulnerable to the toxic effects of environmental hazard exposures, in part due to their chronic exposure to other non-environmental stressors or social stressors, whether that's material hardship related to poverty or racism and discrimination, chronic malnutrition, poor quality housing, lack of healthcare access, etc. So this is kind of a schematic that sort of encapsulates what I've called the triple jeopardy of social and environmental riskscapes. Taking into account social context, that can be about policy or the social inequality, racial residential segregation, and then how this plays out demographically or even spatially and geographically. And there's kind of three main buckets that we are compelled to contend with. One are exposure disparities. These are what I call extrinsic factors. Social vulnerability factors, also extrinsic factors, so lack of access to healthcare, poverty. These extrinsic factors are things that we can change through policy interventions. And then on the far right are biological susceptibility factors. These are intrinsic. Many of these are not changeable. How old we are, whether or not we have children, our genetic makeup. Some of these are not necessarily modifiable, but very important as well. These can come together and cause what we call in epidemiology interactive or additive effects in terms of how certain groups and populations are more vulnerable to the toxic effects of environmental hazard exposures, and this can play out across the lifespan. So So what does it mean in terms of when we're thinking about intrinsic and extrinsic factors and how it increases disease risk? So this is sort of a simplistic schematic here, but if you look at the top, you see the baseline sort of risk where the majority of the population has no adverse health, disease risk for whatever chronic disease we're talking about. Because you're talking about diabetes or hypertension or cardiovascular disease. And then when you look at sort of quote unquote baseline risk and you add the intrinsic biological factors, all of a sudden you have more people who are likely to get these outcomes. And then when you combine both the intrinsic and extrinsic factors, you start to get more and more people who are at risk of these outcomes. And then you can look at it, for those of us who are kind of data nerds, you can look at it more as a distributional schematic where there's no co-exposures on the far left, and so the percent of the population that's getting the disease is very low, and then you start adding co-exposures, but no biological susceptibility, and then co-exposures plus biological susceptibility all the way here, and all of a sudden the proportion of the people who have the disease that you're studying starts to go up due to that variability and the unique vulnerabilities of certain communities due to co-exposures to what I call social and other environmental stressogens. Okay, so I'm an epidemiologist. I focus a lot on environmental and social stressor exposures, particularly as it affects perinatal outcomes, so birth outcomes. I'm also interested in the ways that can affect child development, including neurodevelopment. I'm not going to walk you through everything. I'm just going to give you some kind of highlighted examples of how we study these things. But really trying to understand in terms of how these inequities and exposures, both when we look at them at the individual level, then also when we look at it in the environments in which people function, mostly the easiest to measure is often where people live. And then the life stage at which people experience these exposures also matter, or what we call key windows of exposure. So when we look at perinatal outcomes, we're very interested at exposures either 3 weeks prior to 3 months prior to pregnancy, or which trimester of pregnancy is most likely to lead to adverse perinatal outcomes, reduced fetal growth, preterm birth, or adverse neurodevelopmental outcomes in offspring. So one of the ways that we've been studying these at the individual level is through a cohort study that we have been recruiting now for about 12 years in San Francisco and also in the Fresno metropolitan area. And the study is called Chemicals in Our Bodies. And we have been recruiting people in their second trimester of pregnancy, and we follow them through delivery of their offspring. And then resources allowing, we have been able to follow the offspring to assess their neurodevelopment at different life stages. And we take maternal samples for different chemicals. We've been focusing a lot on per and polyfluorinated alkyl substances, otherwise known as PFAS, the forever chemicals that we see in the news all the time. We've also been looking at legacy flame retardants, polybrominated diphenyl ethers, which thankfully are being phased out, but are still very much persistent in the environment and in a lot of the products that we still have in our homes. And we're also looking at other chemicals, so I'm not going to talk about those today. And then we're also measuring upstream biomarkers of effect. Chronic stress biomarkers. So we're been measuring corticotropin releasing hormone, been looking at telomeres, length and telomerase activity, which is an indicator of cellular aging, which can be accelerated based on chemical and social stressor exposures. And then these are some of the outcomes that we've been looking at today. I'm going to focus on some of the effect biomarkers, looking specifically at corticotropin releasing hormone. Okay, so again, looking at the individual level, one of the hypotheses we had was, what is the relationship between prenatal PFAS exposures and levels of corticotropin releasing hormone in the mother during pregnancy. And we're interested in this because elevated levels of corticotropin releasing hormone, or CRH, is associated with risk of preterm birth, which has huge implications over the life course for offspring. And their literature definitely suggests that corticotropin releasing hormone is not only affected by stress levels, social stress levels, but also by certain chemical exposures. But at that time, no one had really looked at it in relationship to PFAS. So this graph on the right looks at the increase in corticotropin releasing hormone for every unit increase in the different PFAS. I just showed you a subset of them here. And for one species of PFAS, the top one, PFNA, we did see an association between prenatal PFAS exposure and increase in corticotropin releasing hormone, after accounting for a lot of these other factors that might explain this relationship. So this is looking at an interquartile increase in PFNA associated with increasing corticotropin releasing hormones. Then we stratified our participants, looking at those who reported experiencing different social stressors during pregnancy versus those that reported not having those stressors in their life during their pregnancy. And so what you see here, focus on the ones that are in red squares. Again, looking at this particular PFAS, PFNA, and what you can see, the ones that have circles are all the participants that reported either for panel A, reporting a stressful life event like a divorce or having to move or losing their job. The one is reporting depressive symptoms during pregnancy, experiencing food insecurity, and then financial strain during pregnancy. And for each one of these, what we see is that the pregnant people that reported having these stresses during pregnancy, the relationship between that PFAS and the increased risk of corticotropin releasing hormone is much stronger, suggesting that the stressors enhance their vulnerability to the adverse effects of these PFAS exposures. More recently, we've been interested in PFAS, the relationship between PFAS and mental health outcomes, which is kind of a newer area. A lot of us are moving. There's a lot of air pollution research, for example, looking at mental health effects. And more recently, because we're learning about the ubiquity of PFAS in lots of substances that we use every day, but also increasingly in drinking water, et cetera, we've become more interested in this. This is a big deal when you're pregnant. Having depressive symptoms during pregnancy is quite significant and can lead to long-term health consequences, both for the pregnant and their offspring, not to mention significant economic impact for the family. And the thing about, obviously mental health is there's a lot of different factors that can affect mental health, particularly during the period of pregnancy. So again, we looked at prenatal levels of PFAS, and we looked at, this is a screening for depressive symptoms during pregnancy. So anything to the right of 0 indicates increased scores for depressive symptoms during pregnancy. And the thing that's interesting here is we see the strongest effect among our immigrant pregnant people, people who were not born in the U.S., for many of whom, for whom English is not their first language. These depressive symptoms and the relationship between PFAS and depressive symptoms is much stronger. Okay, so this is an example. These are examples at the individual level about ways in which both social and environmental stress can come together to enhance their adverse health effects in a stronger way than either one alone. And again, these are things that we can then sort of translate about the ways in which we can intervene or change policies, which I'll talk about at the end. So then now I'm going to move a little bit more away from the individual and think about what are some factors in people's environments that we want to be taking into consideration. And so one of the things that many of us have started to look at is legacies of racism in policy, and the ways it affects people's lived environments now. And one of the most common ones that we look at is something called redlining. And this is a map of the United States. This is looking at 310 metropolitan statistical areas, so cities and their surrounding suburbs. And this is a measure of racial residential segregation on the right. It's called the multi-group dissimilarity index. And basically it says what proportion of people in a particular metropolitan area would have to move from one census tract to another in order to achieve an even distribution of the different racial and ethnic groups that live in that city. So the beauty of this measure is it allows you to compare a city like Detroit to a city like Portland, Oregon, because it's not as composition dependent. And so you can see in this map, the places that are kind of brownish are considered hyper segregated, where about over 60% of people would have to move to achieve an even distribution. And then the ones that are in yellow are more moderately segregated, less than 40% of people have to move from one tract to another. So we obviously didn't get here by accident. There's books, this is one of many books that have been written about to understand racial residential segregation. This talks about redlining. And this is something that I and many others have sort of glommed on. There's been like a proliferation of redlining studies over the last 5 years. And that's not because we all like got smart and decided redlining was something, there was an opportunity presented to us when the University of Richmond digitized all the redlining maps across the country. And that made that data available to us in a way that hadn't been made available before. So redlining is the result actually of a policy that was a good policy. In the wake of the Great Depression, the federal government created the Homeowner Loan Corporation, otherwise known as HOLC. The goal of HOLC was to bail out people from defaulting on their mortgages in the wake of the Great Depression. So the original policy idea was a great one. The problem was that its implementation was a racist strategy. Okay, and so what happened was people, members of HOLC were spanned out to cities and mapped neighborhoods based on their riskiness for these mortgage bailouts by the federal government. Okay, and some of the criteria for determining whether or not a neighborhood was risky was its racial makeup. So in these digital archives, and along with the data, you can get these descriptions of the neighborhoods that have been redlined. Neighborhoods were graded A, B, C, D. Neighborhoods that were D, as in highly risky, were colored red, i.e. the term redlining. And you can read these descriptions and to get an indication of some of the racist language that was used to justify some of the redlining. So this happened in the 1930s. And so many of us have been looking at to what extent has that legacy influencing the physical makeup of environments now. So one of the earliest studies we looked at was looking at the ability of the distribution of green space, if you will. And in urban areas, similar to the map that I just showed you of segregation. And we published a study in 2021 showing basically that neighborhoods with legacies of redlining in major cities had a lot less green space. And that's after taking into account a lot of other area level variables. That relationship persisted. This is a map of New York City. So these are the Homeowner Loan Corporation grades, and you can see where the red line neighborhoods are. And then on the right-hand side, you can see the distribution of the green space. And then, you know, statistical modeling showed that these relationships were quite robust, doing a lot of propensity score matching to really try and explain away some of the other factors that might explain this relationship. And we care about this because we know, as many of us have, for those of us who spent time in Southern California in the last week or so and wherever, green space can do a lot as an adaptation strategy for increase in frequency of extreme heat events. We have done some work looking at the relationship of extreme heat and risk of preterm birth. And have shown that extreme heat is definitely associated with preterm birth, particularly during the early pregnancy period. And that oftentimes these relationships between extreme heat events and risk of preterm birth are strongest in neighborhoods with racialized forms of poverty. So this is from a study looking at an extreme heat wave in Texas, and then looking at the effect estimates in the circles and the 95% confidence intervals. And anything above 1 indicates a statistically significant relationship. And then we looked at different ways in terms of measuring exposure to heat. So lag 7 means, within 7 days of the heat event. We looked at different lag periods just to look at the sensitivity of our results, depending on how we measured the extreme heat exposure, and then also averaging across exposure periods. But basically, other studies have confirmed this relationship in terms of extreme heat events being associated with risk of preterm birth, particularly during the earlier trimesters of pregnancy. Closer to home, we've also been really interested in oil and gas development and its relationship to adverse perinatal outcomes. We know that oil and gas wells and being near your neighborhood can increase the risk of exposure to air pollution. It can impact water pollution, particularly if for communities that are dependent upon aquifers and groundwater. If you live near these big wells, they often are running 24/7, the light at night and the noise. And then other social stresses are just associated with having these industries nearby. And we, again, leveraging this redlining data, wanted to look at what's the relationship between wells by the redlining grades undertaken by the Homeowner Loan Corporation in 33 US cities that had oil fields at the time that these redlining maps were being made, and that also had oil fields where you could actually drill for oil. And so you can see, if you just look, regardless of time, but with the worst grade, you have the higher number of wells. And then it's important to note here that before these maps were drawn, we can see that, not surprisingly, the wells were higher in the graded D neighborhoods, because one of the criteria for designating a community as at risk was if they had other kind of industrial things going on there, which would make it also a risky place to bail somebody out from a mortgage. But then the interesting thing is, after that sort of appraisal period, the pattern and the disparate impact in graded D neighborhoods sort of accelerates and continues to increase. And again, we care about this because we have, and particularly it's interesting, and I've done a lot of my work on oil and gas development in California. A lot of the focus of scientific studies initially focused, in the Marcellus Shale in Pennsylvania and in Texas, where a lot of the oil and gas and fracking boom really took off very quickly, and that development was really happening. And a lot of my colleagues were seeing relationships with adverse birth outcomes, but ironically, no one had really looked at what was going on in California. There had been no health studies looking at the effect of oil and gas development in California. And the industry was very effective in saying, well, the infrastructure here is different. We don't really have fracking. Only 2% of our wells are fracked wells. There's no evidence to indicate that there's any true health threat going on in California. Our infrastructure is over 100 years old. There's oil and gas wells in Beverly Hills, and we're different here, and we don't have a problem. So we decided to test that hypothesis, and rather than saying that no data means no problem, we decided to generate some data. And because about 3 million people, or, 8% of Californians live within a kilometer of an active oil and gas well. That's a lot of people, so it's probably a good thing to know. So we did a bunch of studies, and we definitely saw significant effects. We saw that our studies showed that living within a kilometer of an oil and gas well, you're much more likely to have a low birth weight baby, much more likely to have a small for gestational age baby, increased risk of preterm birth. And some of these effects were stronger for pregnant folks that were living near the few wells that are fracked in California. And a study by my former postdoc and now colleague, Daniel Gonzalez, which he did in the San Joaquin Valley, saw a stronger effect among Latinx pregnant folks in terms of risk of preterm birth. So we spent a lot of time sort of putting together this evidence. The governor started to get very interested in this in terms of really pushing more regulation of the oil and gas industry, in addition to a lot of scandals that were reported about just the agency that regulates the oil and gas industry, just kind of getting those permits out as quickly as possible. So they convened a public health panel where, which I co-chaired, and we were able to sort of provide the scientific basis to get this legislation passed. SB 1137, which puts some limitations on where new gas wells can get permitted near so-called sensitive receptors, including where people live, schools, things like that. It more severely regulates existing wells, will make it harder for them to renew their permits. Industry tried to stop it through a initiative that they put on the ballot, stopped it on its tracks. And then this summer, industry, after a lot of polling, realized that they were going to lose, and they withdrew the initiative from the ballot, so the law is now being implemented. Although there have been attempts in the legislature to postpone this law for the industry by 4 years, but so far not successful, but stay tuned, we shall see. Okay. And again, this is, actually, I'm just keep moving on. Okay. So, the other thing that we try and do is look at, some of the potential health equity benefits of policies that are being put into place. Rather than continually documenting the problem, how can we flip the switch and look at policies, and look at their co-benefits? So as everybody here knows, we have climate change law, and we've been in the process of implementing it for quite some time with very ambitious greenhouse gas reduction goals. And we wanted to look at what are some of the benefits that we might be seeing with the implications of our climate change laws in California related to power plants. Okay, because we know that power plants emit not only greenhouse gases, but co-pollutants that we already know very well are bad for people's health. And with our new climate change policies, the power industry has to now pay for a ton of greenhouse gas that they emit through the cap and trades. And so prior to the passage of California's climate change law, and then during its implementation, a lot of power companies saw the writing on the wall that some of their power plants were no longer going to be cost effective or very efficient, and they started retiring them. So 8 oil and coal power plant retirements happened over a period of 10 years. And so this provided us with an opportunity, what we call quote unquote natural experiment in epidemiology, to see whether or not we could see any signal for public health benefits on the closure of these power plants. And so we looked at PM 2.5 monitors, which were nearby, which is sort of crude because we didn't have an opportunity to monitor closer to the plants pre and post. But this is looking at the buffer distance from the plant, so between 5 kilometers, 5 to 10 kilometers, and 10 to 20 kilometers. And the blue is the level of PM 2.5 before the retirements, and the average PM 2.5 after the retirements in green. So we see a little bit of a signal that PM 2.5 levels went down, particularly in areas closer to the plants. But what we then we wanted to see, did we see a change in preterm birth rates? Any reductions in preterm birth rates among people who lived close to the plant? And the answer is yes. This is looking at overall reduction, the average differences in post versus pre populations of preterm birth. And the red lines are for the communities that are living within 5 kilometers of the plant, and the orange is between 5 and 10 kilometers. And that's compared to people who live much farther away to account for secular trends in preterm birth rates. So it went down from about 7% to about 5.1%. And what we also saw was that some of the benefits were strongest among Asian and African-American pregnant people. So I just want to put 2% in context. If I were to invent a drug that reduced preterm birth by 2%, people would be clamoring to invest in in this thing. It's huge when you consider the number of births in a state like California. Okay. The other thing that we have done is looking at forecasting some of the potential public health benefits if we were to reduce different types of pollution. An example here is a study that we did in collaboration with a colleague of mine in civil and environmental engineering, Josh Apte, and one of my postdocs. We wanted to look at hyper-localized exposures to traffic-related air pollution in downtown and West Oakland. And we took advantage of my colleagues' really very granular measurements of 3 types of pollutants in these neighborhoods using Google Cards. And they measured nitrogen dioxide, black carbon, and ultrafine particles, many of which are related to both light duty and heavy duty trucks going through neighborhoods. And we asked ourselves, would we see a reduction in preeclampsia, which is a condition during pregnancy, very high risk condition during pregnancy, which can lead to preterm birth and other adverse health outcomes? If we were to reduce the levels of these pollution to the 25th percentile versus what we are observing, what would be the change in the rates of preeclampsia that we could observe? And this is looking at different ways, the circle and the triangle are the different ways in which we measured exposure to air pollution. We used electronic health records from the Southern Health System, geocoded where all these people lived to get the people who had preeclampsia versus those who did not. And what you see is a pretty significant reduction in the rate of preeclampsia risk if we were to get everyone down to the 25th percentile, particularly for nitrogen dioxide and black carbon, a little less impressive for ultrafine particles. But the thing that we saw that was even more striking was that the benefit was strongest for African-American mothers in terms of reduction in preeclampsia. So again, providing opportunities to see how and forecast and evaluate potential policies for reducing certain kinds of pollutants, not only what it means for benefiting overall health, but how it can address potential health inequities for an outcome like preeclampsia, which disproportionately impacts pregnant people of color. Okay, so switching gears, what does this mean for policy, and how have we been trying to address it? Because I had a hard time picking what to talk to you about today. There's such great science on it, and we can just geek out and do all these great analyses. And yet communities feel like there's a lot of really great evidence out there now. So, let's get the show on the road and start doing something now. Let's develop tools to aid regulatory decision-making. How do we do a better job of integrating some of these place level measures of environmental and social stressors? to elevate the communities of regulatory concern where we need to be doing our targeted regulatory oversight. Okay, so one of the two policies I just want to end with is both California's climate change investments policy, which is the result of SB 535, otherwise known as the Greenhouse Gas Reduction Fund. And California led the way with this policy, and this provided the basis for the Biden administration's so-called Justice 40 initiative, which I'll just briefly cover in a second. So, environmental justice advocates did a lot of organizing to pass SB 535, which required that revenue that was coming from the regulation of industrial sources, that, you know, all these industries that now had to pay for the every ton of greenhouse gas that they emitted. They wanted to make sure that that money that was coming into the general fund, a portion of it was invested in environmental justice communities. So it required that 35% of these funds had to benefit so-called vulnerable groups, and at least 25, and now it's higher, had to be invested in vulnerable neighborhoods directly. And the question was, how do you identify those neighborhoods? How are you going to direct those investments? And so this is, many of you may be familiar with CalEnviro's Green. This is the 4.0. We worked a lot. We actually had the precursor to CalEnviro's Green called the Environmental Justice Screening Method. And when EJ advocates who were helping to co-author the bill, they came to us and they're like, we want to require in the bill that they use your environmental justice screening method map. And we were like, no, we don't want to feed this monster in perpetuity. We can't do that. This should belong to Cal EPA, and we're willing to help Cal EPA develop it. But this needs to be adopted by the agency and be embedded by the state. So we worked a lot to help them develop what we now know as CalEnviro Screen. And this is what is used. That map highlights environmental justice communities by using multiple indicators of environmental hazard exposures and social stressor exposures, so that you can look at where the so-called disadvantaged communities are and where you want to be targeting those investments. A lot of money has been appropriated to date. This cap and trade money report comes out every year. You can find out the programs that were funded. And yes, it funds research. So those of you who are interested in getting great research money around cap and trade and equity, or climate change and equity, they do fund research, particularly very interested in community collaborations. And so this California's experience sort of provided a bit of a model for President Biden and the Biden administration's Justice 40 initiative, which has very similar goals. The wording of the executive order on Justice 40 was that 40% of the benefits of programs by regulatory agencies have to go to environmental justice communities. And those of us who sit on the White House Environmental Justice Advisory Council have been trying to help the federal government develop the national version, what they call the Climate and Economic Justice Screening Tool. And they have developed a scorecard to report, you know, how it's going, where the money's going, things like that. So I just want to wrap up here by saying that I didn't talk about my methods in terms of community engaged research. I'm happy to talk more about that any time that we have left for Q&A. But that community engagement, both in the scientific enterprise itself, but then even more importantly, I would say in the research translation process, to how do we leverage the science to then develop policies that not only improve overall health, but that actually reduce the health gap, the environmental health gap that continues to persist going forward. And so I think I try to provide you some examples about how they're changing our scientific thinking, and then also how that has translated into policy initiatives both in California and now at the federal level. And thanks for your attention.
Okay, questions for Rachel, starting with the student public. Students of life have questions? Yeah.
Here, I'm with Carl, under, the vice of them. And I was when you mentioned that some of your study that you were doing, where you were getting, people in the second trimester, I was wondering if you could speak to, where you were measuring, has that changed over the past years, and how do you like account for that in a long-term study? Whether like your methods of reaching out to folks, if that changes, and how you measure, like what you're measuring, how that changes over this long time. Have you-
Yeah, so that's a great thing. When you do these 12-year studies, things do change. It changes often, because methods get better. Labs can measure, chemicals at lower levels than they were when you first started. So you definitely have to take those things into account when you're like doing statistical analysis and things like that. And then there's, just, for example, we expanded the cohort. The cohort started in the San Francisco Bay Area. We were recruiting for people from San Francisco General and Mission Bay hospitals. And then we expanded to Fresno hospitals, very different population, very different clinical setting. We also had to deal with COVID-related shutdowns where they weren't letting any researchers in any labor and delivery places for a long period of time. So we had a huge gap. We're still trying to collect data remotely. So I don't have a holistic answer about how you address it, but those are definitely issues that you grapple with. And then not to mention keeping the thing going, money. You collect all these great samples and then, you try and write grants, and sometimes you score and many times you don't. So you try and preserve your data as best as you can, and then just try and keep getting resources to measure it later on down the road. The other thing that we have been doing is also trying to get, we've gotten resources to return results to study participants who want them. So a lot of participants are very interested and they're very motivated to support the scientific enterprise. They want to contribute to science, but understandably, they also like, what did you find? Like, what kinds of chemicals are in my body? So we have managed to find resources and develop some really nice interfaces and capacity to return those results to participants.
Yeah, I'm wondering if you can expand a little on your participatory and collaborative approach. Which stages of the research process were participatory, and what were the main challenges you faced?
Yeah, so the cohort study, I wouldn't call a community-based participatory research project. We have a participant advisory board that gives us a lot of advice, but it's not like we sat down and wrote the proposal together. So some other, my more sort of deeply engaged participatory studies, the ones that I like to do are where groups reach out to me and want to do something. And you start out with a conversation, because oftentimes people are like, we want to know whether the refinery enrichment is causing asthma in our neighborhoods. Very, very straightforward, really great question, extremely hard to answer from a statistical point of view. So you have to have a really candid discussion about like the limitations of science to answer a really important question. Then you start to move toward, sample size, case enumeration, all these kinds of things. And then you start to move, okay, so maybe we can't do an epi study because we don't have resources or whatever. Statistically, it's a very big challenge. What can we do? So very often you start thinking about exposure studies. What is it that you really want to know? Well, we want to know how the oil refinery is affecting our air in our homes. Like, okay, well, we can measure your homes from pollutants coming from the oil refinery. And then we already know the literature says it's bad. So that's, and then you start writing a proposal around that. And then you have very serious conversations about what's going to happen if our analysis does not validate community wisdom about what we going on, how are we going to deal with that? And you need to have that conversation before you do anything.
And one back. Yes.
Thank you. Great conversation. Thank you for sharing the knowledge with that. I have a question in terms of community-based organizations or community organizations, stakeholders. Sometimes it is very difficult to engage with them because they don't have the resources, the infrastructure, the governance, whatever.
Yeah.
And oftentimes when you apply for a grant, the grant doesn't consider development of this infrastructure, this community-based organization will pay for collecting the data and paying for equipment, whatever, but the community-based organizations are left out. Has that been a problem for you? It has been a problem for others, like before, and how have you been able to overcome that, if so? Because the issue with the community-based organizations, like you say, they ask the question, valid question, is this thing impacting our communities? How is it? And you say, okay, let's do a study, and they might not have the means, and then you're not out the grants. Have you run this problem at all, or?
Yeah, I mean, you spend a lot of time first discussing what level of participation in scientific work do your partners want to do? So I've done projects where, like, from day one, they're doing data collection, and we are able to budget for them to hire people, pay their labor, you know, for the entire duration of the project to ensure that they are well paid for helping to do field work. Then there's other organizations though that don't want to do that. Because they see it as potentially leading to mission. They want to participate, they want to have say and everything. But they do not want to dedicate all the resources to do the actual field work. So very often in that case, we have leveraged secondary data to try and answer the questions. So we don't actually have to do, there's a lot of great data out there. And if you can find the right data, sometimes it's administrative data, sometimes it's other people's cohorts. You can actually answer a lot of questions and engage people in the analytical process and not necessarily have to do primary data collection.
Back.
I'm not, that's funny. I was curious if you have any understanding of the why. I can really affect for information. Could be, yeah.
Yeah, for PFAS. I don't know. I honestly don't know. This is where we've been, we've been unsuccessful so far in our grant application to explore this further. We published that article to show that there was a relationship, and then there have been some other studies that show similar associations. And the grant that we were writing was to try and understand some of the biological mechanisms and pathways by which PFAS affects depressive symptoms. But so far, viewers haven't been in love with it, so we're still banging our head against the wall.
One more? Yeah.
Hi, Rachel. Thanks for your talk. Really interesting. My name is Juan, and I'm a visiting scholar in ESPM, and I'm so curious about the results that you showed about the race. Like, race really matters when you remove shut down the power plant, and sometimes the Black American, they benefit more from like store their ability to get the return material, or like return work, and sometimes it's like the Asian people, and sometimes it's Latin American. So do you think, so what caused it? Do you think it's a more genetic thing?
No,
Or it's more like social kind of thing?
I think it could have to do, there's no genetic explanation for why you would see that. It's likely has to do with differences in exposure levels in terms of proximity to the plants. It could also have to do with co-exposures to other social stressors, and the fact that the rates are already higher in these groups. So the level of, there's a lot more room for improvement, if you will, once you take away a major source of exposure. But yeah, there's definitely, I mean, the literature is pretty clear that the persistent racialized disparities in these bad perinatal outcomes are not genetically driven.
Well, thanks everyone.
Yeah, thanks.
Damien's next week. It's gonna be awesome.
I
Yeah.